Hello friends, welcome to Medicina 101. Today we will talk about the pathology aspect of the cardiac part. So this is the cardiomyopathies. Okay. So from the term, it's very easy to understand whatever the problem you can have there. In the myocardium of the heart, there will be some pathogenesis. Okay. So some pathology of the myocardium layers of the heart. Okay. So before starting the topic, let me just tell you something that just you can write down here that the high blood pressures, coronary heart disease, the congenital heart disease is the coronary is the congenital, and the valvular heart disease and the inflammations. These things are exclusive. Okay, these are the exclusive of the cardiomyopathies. Okay, so just keep in mind these things, that the high blood pressures or the hypertension, the coronary congenital heart disease, okay, the coronary heart disease, the valvular heart disease and the inflammations. These things are not related to the cardiomyopathy. We can say it's the exclusives. Okay. So on the basis of that, the cardiomyopathies we can classify in the three types. So let me write them there. The cardiomyopathy we can divide into three types primarily. So first part we can write it here, the dilated cardiomyopathy. Dilated cardiomyopathy. And the second part we can write hypertrophic cardiomyopathy. I'm writing CM stands for the cardiomyopathy. Okay. And the last one is the restrictive cardiomyopathy. Okay. Now let's go step one by one. Okay. So first of all is the dilated cardiomyopathy. Dilated means there will be dilation of the ventricles. Okay. So let me draw here. I will talk about the etiologies and the pathogenesis later. Let me just tell you the brief discussion first. Okay. So whatever the problem you will see here, let me draw it more clearly for you. Okay, let's suppose the left ventricle, and definitely there is the aortic valve here. Now whatever the problem you will see, this ventricular part will be what? Dilated. Actually the sphere will be like just like this. It will be dilated. Okay, there will be what? The dilations of the ventricles. Dilations of the ventricle. So you can write it here. Of ventricle. Whatever the problem you will see here, whenever the dilations will be there, definitely it's easy to understand that this regions will be what? That will be definitely, if the dilations is there, so it needs the more amount of the force to contact. Okay, so it will be what? Hypokinetic, or you can see in the overall, you can see the hypokinesia. Overall part of left ventricles, of the both ventricles, for the right ventricle as well, we'll see it will be the hypokinesia. We'll see the hypokinesia. Hypokinesia means the less movement or the less contractility there. Okay, so less contractions of the myocardiums. So you can say hypokinetic heart. Okay, hypokinetic here. So whenever the hypokinetic will be, so definitely the movement will be less there. So the movement will be less. Ultimately, in a term, you can say the contractility that will be severely decreased. The contractility that will be severely decreased in this cases in the dilated cardiomyopathy. So the thing is here, if it is too much dilated, just try to understand. If it is too much dilated at the time, whenever during the time of the systole, it will be not able to contract properly. So whatever the problem is here, the systolic failure. But if you think about the dilations, like for the diastole, at the time it can accumulate the blood normally. So there will be no problem as far as the diastole is concerned, but there will be the problem systolic failure of the heart. Okay, so whatever the thing we'll see here is the systolic failure. systolic failure, but the diastole that will be normal, okay? Because the heart, the ventricles can accumulate the blood. Accumulate the blood. Okay, I'll talk about this part in details later. Let me introduce all of them shortly first. Okay, so what did I say? Let me repeat once again. In the dilated cardiomyopathy, you will see there will be dilation of the myocardiums. So as a result, it will be hypokinetic. Hypokinetic means less movement. So as a result, we will see the contractions, the contractility power of the heart of the myocardium, that will be less. As a result, we will see there will be a systolic failure of the ventricles. Okay, so ventricles, but there will be no problem as far as the diastole is concerned, because it can accumulate the blood from the atrium to the ventricles. Okay. Now the next one is the hypertrophic cardiomyopathy. Hypertrophy means, you can understand from the basic term, that it will be proliferations of the cells, or it will be enlarged. Okay, so let me draw it here. Whatever the problem we'll see here. Is the right ventricle, for example. Okay. Now we'll see there will be proliferations of the myocardium. Let's suppose. Okay, let me use another color for it. Okay, let me use this one. Yes. So there will be proliferation, and definitely the valve is your aortic valve. Okay, so there will be proliferation of the myocardium. So over here, so proliferations of the myocardium in these regions. So the number of the and the size of the myocardial cells, that will be increased. But the thing is here that the proliferations will be maximum within the septal regions, interventricular septal regions, in these regions. So let me a little bit clear for it. Okay, so whatever the thing you see, the proliferations of the myocardial cells, that will be maximum within these regions, in the septal regions here. Okay, in these regions. Now what type of the thing you will see here, that in these cases, the more amount of the myocardial cells, okay, as a result, or whatever the thing will be here, it will be, the contractility power will be more. So the heart will be hyperkinetic here. So it will be hyperkinetic. So you can see in these cases, we can say it will be hyperkinetic. So the hyperkinetic is here. So definitely you can say from the aspect that the contractility will be more. Definitely that will be severely increased. But whatever the problem we have to face here, that when we try to understand, whenever the heart, the ventricle is squeezed, at that time this part, okay, try to understand, this part will bulge, out, and there will be like what? Additions of this part with this lifted parts of the aorta. Okay, there will be like what type of the, okay, some type of the collisions a little. Okay, so as a result, whenever this blood, whenever this will squeeze, the ventricle will squeeze, this will bulge out in these directions. As a result, whatever the blood is coming out, whatever the blood is present here, this blood will be not able to go sufficient amount from these regions to the aorta. So on top of the thing, obstruction we will see here. On top of the obstruction, we have to see here there, okay? Because whenever the heart is trying to squeeze, but these proliferations or this thickening of the myocardium, that will just bulge with these regions. As a result, the blood that will be not able to go out from these regions to the, from this part to the aorta, to the other regions. So as a result, whatever the thing will see, the obstruction, on top of the obstruction we will see. If we see it more clearly, let me show you here, just like this. So it will bulge out. So we will do obstruction. So another name for this thing is that hypertrophic obstructive cardiomyopathy. Okay, so we can say yes, I got it. Sorry. So whatever the thing we see here, hypertrophy, obstructive cardiomyopathy. Let me repeat once again. That this myocardium will proliferate. Okay, whenever the myocardium will proliferate, at the time the heart will be hyperkinetic. But here it was hypokinetic. Whenever the hyperkinetic heart is there, definitely the contractility will be more. And whenever the contractility is more, the more amount of the blood will try to push. Okay, the ventricle will try to push more amount of the blood. But the blood will be not able to go from these regions to these regions because of the bulging. Okay, this thickened part will just bulge with these regions. As a result, there will be on top of the obstructions. So sometimes you can also see on top of the like the pathological sounds, murmurs. We'll talk about this thing later. Okay. For instance, just believe you that there will be hypertrophic obstructive cardiomyopathy. So another term for the hypertrophic cardiomyopathy. And another term for this is dilated cardiomyopathy. That is the congestive cardiomyopathy. I'll talk about why is these things. Okay. Congestive cardiomyopathy. Okay. And whatever the thing we see, if we see the structure, actually we will get a like banana shape structure. We will get it here. Yes, we will get a banana shape structure. So the bulging, if we see the structure, we can get it here. And in this case, we will get a balloon shape, just like a balloon. Okay. I have to talk about the restrictive. So these are the very brief discussions. I'll talk about each of them in details. Okay. Now whatever thing we see in case of restrictive cardiomyopathy. Now let me show you here the same thing. The myocardium. But whatever the thing we see, there will be some pathological infiltrations. Within the myocardium, if we see some pathological infiltrations, it's maybe like the amyloids, okay? It will be some viruses, things like that. So within these regions, actually, let me show you more clearly for this. Within these regions, if you see, you will see there will be like pathological infiltrations. Within these regions, we will see pathological infiltrations. So infiltration. Okay, there may be depositions of the amyloids. Remember, like so, these are the secondary for this period. Whatever the problem we'll see here, the problem will see that whenever the heart will contract, there will be no problem. The heart will contract because there is no problem within the myocardium as far as the contract rate is concerned. But whenever the ventricle will try to relax, at that time it will be not able to relax. It will be not able to expand it from these regions. It will be not able to expand it like this. Okay. So in these cases, whatever the problem will see, there is a diastolic failure. Diastolic failure. Okay. Now I will talk about in details the dilated cardiomyopathy. So I already draw this diagram here for saving the time. So I'll talk about the dilated cardiomyopathy. Whatever the problem we see here, and its pathogenesis. Okay. Now see these things. Whenever we are just using this term dilated, that means it is getting dilated. This region is getting dilated, and this ventricular parts, myocardium. Okay. Now, if you see normally that I already said you have the hypokinesia. Okay. So whenever there is hypokinesia, the heart is not able to contract the, there will be problem of what? Systolic problem. So the blood, whatever the blood is coming here, that will get accumulated. And let me talk to you here. If we can consider in terms of a bucket. Okay. And we know that during the rapid ventricular filling, whenever there is rapid ventricular filling of the blood and the cardiac cycle of you read all of these things, at that time this blood will come here and that will produce a sound that is known as S3. So whenever the rapid ventricular filling will be there, this already accumulated blood. Why the accumulation is there? Because the heart is not able, heart is hypokinetic, so the contractility power that is severely decreased. As a result, there will be no sufficient amount of the blood to be ejected from these regions to the outer regions. Okay. Now, in the same thing we'll see in the right ventricle also. It is the right ventricle, for example, it is the left ventricle. Okay. Whatever the thing we'll see, it's the very basic things that we know that from the all over the body parts the deoxygenated blood will come here. Okay. The deoxygenated blood will come here, and from here this blood will be pushed by the what? Pulmonary artery. This is the pulmonary artery. Pulmonary artery. Now, whenever the blood is going from here, okay, then this blood will come here for the what? For the oxygenations, for the purification. The oxygen will be taken, and the carbon dioxide that will be expelled out. There is a different thing. Okay. Now, whenever the oxygen will be taken, after that, it's the very basic things. Oxygen will be there. Then this oxygenated blood that will be sent by the pulmonary vein. Pulmonary vein to the left atrium, from the left atrium to the left ventricles is the thing. Okay, now we'll see here. Okay. Now whatever the problem we'll see here. Now the very basic concept here that we know there is a presence of the valve. If we talk about in these terms, so there is a presence of the mitral valve, for example. Say. And if you see the mitral valve here, okay, let me erase this part. For understanding purpose, try to understand, is the mitral valve, we know there are two leaflets are there, but there are two leaflets, right? Two leaflets. So during systole, the leaflets are coming together and just fused together, and they are preventing the backflow. Okay, but whenever the ventricle is getting dilated, at the time we will see what will be the size of the leaflets of the valve. That will be more. Whenever it is getting stretched, as a result, we will see there will be also a stretchment of the valve. So leaflets, for example, the leaflets are here, the leaflets are here. Now, whenever during the systolic time, whatever the problem will be here, these valves will not able to come to each other to fuse. As a result, we will see these two types of the leaflets. The valve then will go upward. They will get upward. Okay. As a result, we will see the mitral valve regurgitations. So we'll see the mitral valve regurgitations. And in the same thing, if we see here in terms of the right ventricle, okay, if we see in terms of the right ventricle, let me show you here. For example, okay, let me show it. We know there are three leaflets are there. The same thing we'll see here. So as a result, whenever it will be dilated, okay, whatever the problem we'll see here, same thing. So they will go upward, just like these things. Whatever the problem, this tricuspid valve, this is the tricuspid valve regurgitations. Okay, now let's go to the other. Now, whenever the blood is getting accumulated here and the heart is not able to pump them outside, okay, as a result, we see the pressure within the ventricle will be more. The pressure that will keep on rising. As a result, the pressure there here will be also more. Okay, as a result, we will see the pressure here will be also more. In these regions, the pressure will be more. Pressure will be more. And whatever the problem we will see in terms of the right ventricle, so we know the right ventricle will send the blood to the lungs for the purifications. As a result, we will see the same thing whenever it is not able to pump the properly. As a result, we will see the pressure that will be also elevated here more in amount. Okay. In the same thing, we will see the pressure similarly here. The backflow here will be also more. The pressure here will be also more within the lungs. As a result, whatever the thing, we'll see the pulmonary edema. Okay, we'll see the pulmonary edema. Okay, within the pulmonary edema, whatever the thing, we'll see the cough, the dyspnea, hemoptysis. Hemoptysis, many things are there also. Okay, and whatever the problem we'll see here, the same thing in this, for the same regions, this right atrium to right ventricle, this left heart part, okay, so right heart part, that will be not also able to drain the blood from the peripheral organs. So from the peripheral organs, so as a result, here will also pressure will be more in this region. It is not able to bring the blood back to its, to its own part. And the same thing, we will also see the pressure here will also more. As a result, within these regions, the pressure will be more. This fluid will also come out. The hydrostatic pressure, if we see in terms of the hydrostatic pressure, that will be elevated here. As a result, this fluid will also come out, and they will form the generalized edema. It will also form the generalized edema. And whatever the problem we'll see, for the same regions, for the congestion's purpose, whatever there is, accumulations of the blood, or we can say the congestions of the blood, this from here, the left ventricle, right ventricle is also unable to take the blood, so the right heart is also unable to take the blood from this liver. So whatever there will be accumulations of the blood within the liver, so there will be no proper accumulations, okay, no proper drainage from the liver. So as a result, we will see the size of the liver that will be increased. So as a result, we can see also there will be hepatomegaly. So there will be also hepatomegaly. Whatever the things we saw here up to this much, that whenever the heart is not able to pump properly, as a result, we will see the pulmonary edema, we will see the hepatomegaly, we will see the generalized edema also. Okay, so these are the normal things as far as the dilated myopathy is concerned. Now we'll talk about its etiologies. What type of the etiologies we can see here, and their classifications as well. Hope you understood to this much. Now, whatever the etiologies are here, or the positive agents for the dilated cardiomyopathy. The first thing is the alcohol toxicity. Alcohol toxicity, you can say the very the vitamin B complex deficiency. Oh. Okay, then you can see here the pregnancy. Sometimes you can also see this thing. Yes, I think pregnancy, for the pregnancy purpose you can also see. Then you can also see the cocaine. If someone takes the cocaine for a long time, okay, then this type of the problem will be there. If someone takes the cocaine, there will also problem with the coronary artery. There will be vasospasm. That's a different thing. I'll talk about this things in subsequent parts. Okay, if I get time. And some types of the drugs is important on drugs. For example, if someone takes some anti-cancer drugs, there is also chances for the having development of dilated cardiomyopathy. Whatever the drugs we can see here, doxorubicin. So doxorubicin, if someone takes the anti-cancer drugs, doxorubicin, in these cases we see there is a chances there may be some development of the dilated cardiomyopathy. There is a chances for the development of the dilated cardiomyopathy here. Okay, for the doxorubicin. Okay, now we'll talk about actually till today most of the cases for these things is still it's considered as the idiopathic for the dilated cardiomyopathy. Idiopathic. Yet, in the recent discovery, there are some genetical factors about what I am going to talk right now. Genetical factors. Okay. Whatever the genetical factors we see here. Now let me show here once. Now let's suppose the myocardium. myocardial cells, without myocardial cells. So definitely within the myocardial cells there will be the active myosin filaments. So let me represent these terms. In this case is right like this. And just bring this properties here. Okay, just see this structure. This is the normal very basic structures you know from your childhood. These things. That is good knowledge. Okay. Now we know there will be in between them the myosin, the heavy chain. Now, the recent discovery is saying there is a presence of contact of the protein on the basal membrane that is known as dystrophin. For example, there is a protein that is known as dystrophin. Now, this dystrophin protein that is getting attached with the sarcomere regions or the contractile unit, okay, sarcomere regions. Now, it will just what it will contract it will help for the contraction purpose, okay. It is in the basal membrane on the extracellular surface, okay. Now for example, for whatever the regions, if we see there is like mutations in the dystrophin, so there are some genes which makes the protein dystrophin, that is it's intramembranous protein, definitely it is coming through the membrane, it is presenting along with the membrane, so it is intramembranous protein. So it is an intramembranous protein. Now for examples, for whatever the cause of mutation, the mutation is there for the genes that is making the dystrophin protein. Now whenever the dystrophin protein will be there, mutations in the dystrophin, so the dystrophin will not be able to work properly. As a result, we see the contractility that will be very less, severely decrease. And the theories, it's concerned also as well, like the dystrophin protein, okay. Whatever the thing you can see here. Within the mitochondria, definitely the mitochondria will be there. In these regions. So there may be sometimes there is some chances for the mutations of some enzymes. Within the mitochondria there is some presence of some enzymes, oxidative phosphorylations. So oxidative phosphorylations. There are some enzymes involved in the oxidative phosphorylation present in the mitochondria. Phosphorylation. So if you see any type of the mutation in those enzymes that is responsible for producing the ATP, so there is also chances for the what? Dilated cardiomyopathy. And another study is saying that the mitochondria, this mitochondria definitely uses the fatty acids for the energy production. Okay. Now there is some enzymes, okay, that helps in the beta oxidations of the fatty acid. Now if you see there is also the mutations in those enzymes that is helping the beta oxidations, so that also as a result we see this ATP or the energy that will be severely decreased. Okay. So from the Laplace's law, what do we know? That P varies, what do we know? P varies T by R. And in these cases, what did you see here up to this much? T stands for the tension, is R for the radius. Definitely in the dilated cardiomyopathy, undoubtedly we can say the radius that will be more because it is getting dilated. Okay. And whatever the tension means the force. Now, if the energy production is not enough there, so the tension will be less. Along with that, if the dystrophin protein is not working well for the mutation purpose, then the force, generating force, that will be also less. So the radius will be more, that is getting dilated, and the tension that will be less. As a result, we will see the pressure, there will be fall down within the pressure. Fall down within the pressure. Okay. Now, this was all about very little discussions about the dilated cardiomyopathy in the subsequent part. Actually, if I just talk about all the parts like this, dilated, restrictive, and also the hypertrophic, then it will take long time. So I'm not thinking to make the videos large. So for the very brief discussions and also the conceptuals and some latest things you need to remember from here. And a little bit about the hypertrophic obstructive cardiomyopathy. Now let me tell you here the hypertrophic obstructive cardiomyopathy in the second part. In the second, I already said you some genetical factor. Whatever the genetical factor is all about the 100% genetical factors. Okay. Now near about the 50% of the cases the familial, and 50% of the cases we can see here sporadic. Now out of the 50% familial here, it's autosomal dominant. If autosomal dominant, that means we can say that if one gene is getting defected, for example, if one gene is getting defected among the two alleles, or one allele, one gene is getting affected and this gene is normal, this patient will be have this type of the problem. So these are about the recent studies that has been discovered, and see you in the next video about the hypertrophic obstructive cardiomyopathy. Okay, so if you like the video, please do subscribe my channels and let me know in the comment section how's the video and how can I improve more. If you do have any doubts, let me know in the comment sections. I'll try to help you guys with my level best. Okay, thank you for watching.